So now we are going to start our first session this morning, understanding how stress and resilience interact to influence child brain development. So we have three speakers, and I would like to remind every speaker that you have 30 minutes, so please stick to your time. So our first speaker is Dr. Robert Sege. He's a professor of medicine at Tufts University School of Medicine and serves as the director of the Center for Community Engaged Medicine at Tufts Medical Center. His talk today is entitled Translating Science into Practice: Hope, Healthy Outcomes from Positive Experiences. Dr. Sege, please.
So first of all, thank you, Barbara. Thank you, Dr. Tsai. It's such a pleasure to be here. I was here at a symposium in the before times, and it's nice to be back here again. And when I say nice, it's a little intimidating because one of the things I'm going to try to do is convince everyone here about neuroplasticity. So I think I'm going to just skip over that lightly and assume that you know it. So I'm going to talk about hope, healthy outcomes from positive experience. And as a translational science exercise, all we're trying to do is simply transform care for children and families everywhere, all at once. That's our goal. And we have a wonderful team. Dr. Burstein is sitting in the back in the middle there. And we have many of our other team members on the web right now. And the work I'm describing, I get to describe, but it's a collective product. We have an amazing National Advisory Board. We have a group of advisors called the Family and Community Experts of Hope. Who knew that would spell out Faces of Hope? What a surprise. And we also have an innovation lab that I'll talk about. So the work we're doing has been so fun and so enlightening because we have so many diverse voices putting this together. So I told you we're trying to transform care everywhere all at once. And the problem is a really, really big problem. In the United States, through the 20th century, life expectancy slowly increased every year. In the 21st century, it's plateaued. And that hasn't plateaued in the other wealthy countries. It's continued to grow. And one of the sources, and Dr. Tsai mentioned this, is the injustice in the United States that results in a spectacularly large gap in life expectancy between Black Americans and white Americans. And so when we do this work, looking at diversity and having an anti-racist agenda is not an add-on, it's primary if we're going to improve the health of the population of the United States. So that's all good, but I want just to point out what are the leading causes of death in the United States: heart disease, cancer, injuries, chronic diseases. And I'm listing these because, as we'll see, childhood experiences have profound impacts on each of the leading causes of death in the United States. And some of the disparities that we see can be tracked back to the childhood experiences that Americans have. So what we're doing is improving care, but our goal is to improve the public health. And I mentioned that we're using the paradigm of translational research. Many of the people at the Picower Institute do basic science and answering fundamental questions. We're starting there, and then we're moving on through applications, through implementation, through practice, and looking at the impact both on individual children and families and on the systems that serve them. So with that, I'm going to start and look at some of the fundamental questions. And I joked at the beginning about neuroplasticity, and so much of the work has been done here at the Picower Institute with you and your colleagues. But just to bring everyone up to date, experience and learning call on multiple cells, and those connections grow with experience. The connections can be visualized, and strong connections form these myelinated, insulated, fast connections, which you can see in brains as children grow and develop. And here's the headline: although I'm a pediatrician, even old people, and by that I mean people 22 years and up, still have neuroplasticity. So it's important. And some of the work that was done, this is a beautiful figure from Chuck Nelson at Children's Hospital, and then a lot of people here have worked with him, really looking at adverse childhood experiences and how they affect brain development, looking at what happens, what we see as children, what happens biologically. There are epigenetic changes, there are neurodevelopmental changes, there's reprogramming, and the end result are changes in adult health. And this has been mapped out, still a lot to do, but with all due respect, this study really looks at the adverse childhood experiences. This study looks at the adverse childhood experiences, which are on the far left of that, those experiences that children have. And for those of you who are not familiar with the 1998 ACEs study, which has been repeated many times over the years, individuals who have physical, emotional, or sexual abuse, physical or emotional neglect, or live in homes where there's mental illness, incarceration. Initially, it was mother treated violently. More recently, it's intimate partner violence, period, substance use disorder, divorce, or separation. The more of those experiences that a person has, the larger the health effects. And the CDC published a very important paper a few years ago that looked at all of the downstream effects from adverse childhood experiences. And so it goes with traumatic brain injuries, it goes with mental health, with maternal health, with infectious disease, chronic disease, risk behaviors, and opportunities. And I'm saying all of this because remember in that second slide I showed you the leading causes of death in the United States, and you can just tick them off, how they're affected by ACEs. So when we think about population health in the United States, the work that's going on here and elsewhere about neurodevelopment and the importance of childhood experience is remarkably important. But I'm going to pivot in just a minute because that's all about adverse childhood experiences. And children experience adverse childhood experiences, they experience positive childhood experiences, and they just experience life, right? But the things that we've learned from the trauma-informed care revolution are, number one, children's brains respond to experience. It makes a difference in how we grow and develop as children. Number two, ages birth through 3 and adolescence are sensitive stages for neurodevelopment when our environmental exposures really make more of a difference than they do at other points in our lives. There's a therapeutic importance, and both in terms of understanding a child's behavior based on those experiences and using that to help heal the children afterwards. And because this has been so well publicized in the United States, who hasn't heard of a trigger warning or trauma or those sort of things? Most adults now really understand that childhood experience matters for our brain development, and think of how that matters as we're changing public will and public understanding to have that basis. But the other thing we now know is that people can heal even after past trauma. So sometimes I speak with a variety of people. Some of them provide therapy, trauma-informed therapy for people, and the people get better. Their symptoms get better. They're in less distress, but their ACEs score is still the same. So ACEs is not the same as destiny. Other things happen. But I want to pivot for a second, no, not for a second, for the rest of my talk, and talk about positive childhood experiences. Because we know that children's brains respond to positive experiences as well as adverse experiences. And one of the classics work in brain plasticity has to do with adults who've had a stroke. And it used to be that you had a stroke, part of your brain died. If you can't control your right arm, get the person a sling so they don't go off and hurt themselves. But now we know that with intensive therapy that ranges from physical therapy to cognitive therapy, visualization, brains can recover. And the cool thing is when you look at a functional MRI, it's not that those cells are reincarnated, it's other parts of the brain take over. And our brains, even as adults, are able to rewire. The second positive experience, which is so important for children, is the development of literacy. So we now know that when people become literate, you can literally see on an MRI the increase in connections between the visual cortex and the speech center. Pretty amazing that you can watch that. So if you take an MRI of adults, teach them to read, look a year later, you can see a difference. And more recently, this has been applied looking at kids who have different needs. So when they teach autistic children to read, you can see changes in brain activation that are lasting beyond the lessons. So we know that neuroplasticity is important in reading, in literacy, and all that that leads to. And it's hard to speak now in this post-pandemic age and not talk about post-traumatic growth. We all know about post-traumatic stress, but there's also recovery. People recover from trauma, assuming they're not killed, of course, and you can see changes in their brains. So in a series of famous studies done in Japan after a large earthquake, people who survived that trauma had changes in their brains that you could visualize on MRI that correlated with post-traumatic growth. And all of this is to say that it's not just adversity that changes our brains, it's all of these experiences. So with that, I want to go and talk about the applications and synthesis. So that's the basic science. So what does it mean for human health? So our first big study, which was done with a bunch of people, I'll tell you in a moment, with Christina Bethel and Jennifer Jones and Jeff Linkenbach and others, we took the 2015 population study in Wisconsin. This is a periodic survey done by the CDC through each state. It's called the Behavior Risk Factor Survey. It asks about risk behaviors and about current health status. It already included questions about adverse childhood experiences, or ACEs, and we added 7 questions about positive childhood experiences and correlated those with mental health. So the PCE scale asks 7 questions. Thinking back to when you were a child before the age of 18, how often did you feel able to talk to your family about your feelings? How often did you feel your family stood by you? How often did you enjoy participating in community traditions, feel a sense of belonging in high school, feel supported by friends, have at least 2 non-parent adults who took a genuine interest in you, and feel safe and protected by an adult in your home? These questions were derived from a survey called the Child and Youth Resilience Measure from Canada and developed for the World Health Organization. And we used that one because it's been used in 12 countries around the world at the time, so we thought that it was not as culturally biased as other studies might be. And what we found in a paper that was published in 2019 is that of those individuals who had 6 or 7 of the 7 possible positive childhood experiences, 87% reported good mental health. Of those who had only 0, 1, or 2, only half did. And just parenthetically here, good mental health is shorthand for never having had a diagnosis of depression and being in good mental health now. So we can argue whether that's a good definition, but the correlation is extraordinarily strong. So then we looked at people who had 4 or more ACEs. So those are people who had 4 or more of the 3 kinds of abuse, the 2 kinds of neglect, and the 5 kinds of family dysfunction. So they really had difficult childhood. If they had 0, 1, or 2 positive childhood experiences, more often than not, they had depression or poor mental health. If they had 6 or 7 of the positive childhood experiences, it was only 1 in 5, 21%. So what this shows is that positive childhood experiences can mitigate the effects of adversity. And the late, great Carl Bell once said, protective factors are not predictive factors, risk factors are not predictive factors because of protective factors. And this is really data that supports that. So we published that in 2019, and it's been redone in many places. I want to just call out a couple of them. A recent paper from Montana. Of course, we're interested in substance use disorder and the epidemic of overdose in the United States. And what they found is that higher positive childhood experiences are associated with lower substance use. And the items in the survey included less cigarette smoking, less alcohol, lower lifetime odds of any substance, and lower lifetime odds of illicit drug use. This was published last winter from people in Montana. In Tennessee, they also added these same questions to their behavioral risk factor survey, and they published a report on the Department of Health website. And Tennesseans who had more positive experiences had lower rates of depression, similar to Wisconsin, but also lower rates of heart disease, and in particular cardiovascular disease, the most common kind of heart disease. They had overall improved physical health, and they were more likely to be employed. So think about that. These are the positive experiences that really matter. And finally, in Australia, they did the National Longitudinal Survey of Australian Children. They took a group of 5,000 babies who were born in 2004 and 2005 and surveyed them every other year until most recently when they were young teenagers. And they reanalyzed those surveys using the HOPE framework, and they found that the more positive childhood experiences children had at any point during their childhood, they had improved mental health as young teenagers and better academic skills. So the science, the basic neuroscience, translates into human health. Positive childhood experiences matter. So how do we implement this? So there are literally hundreds of papers on positive childhood experiences. And Dina and I and our team have been doing a scoping review of all the kinds of positive childhood experiences that matter. But we've developed a scheme with the help of Charlene Harper Brown at the Center for the Study of Social Policy, and identified 4 key types of experiences that children might have that would be helpful. Relationships, safe and equitable and stable environments to live, learn, and grow. Social and civic engagement, so that children develop a sense of belonging, connectedness, and mattering. And emotional growth, opportunities for emotional growth, which happen through child-centered play, through exposure to nature, through spiritual experiences. And Dr. Tsai mentioned at the beginning that there's a whole part of this that has to do with justice. And when we talk about these building blocks, they seem a little vague, and that's on purpose. That's because people have different families, they have different values, different relationships, different things they want to engage in. The building blocks are fundamental, but what they mean to you and your children and your community, it varies an enormous amount. So we have this slide in just to remind us that there are all kinds of families, and all of them do this. So what we're working on now is transforming care with hope. And just want to go back and say the building blocks themselves are not new. We did not invent the concept of relationships. I think even when Dr. Dworkin was in medical school, they already knew relationships were important. But currently, our practice is deficit-based models that look at threats to these building blocks. What we want with hope-informed care is to identify, honor, and promote positive experiences, and the training we do focuses on changes in mindset, awareness of our own and our other people's cognitive biases, and techniques for incorporating hope into goal-concordant or goal-directed care. So let's dig into that. So relationships, very important. Standard practice is to screen for threats to relationships, intimate partner violence, parental mental health, clearly important in developing safe, stable, nurturing relationships. But hope-informed practice goes a step further. We look at a broad spectrum of things about early relational health. We ask parents, who helps you with your parenting? And we ask children and youth, who besides your mom and dad cares about you? Really important questions which get at beyond the threats into the positive experiences. Think about the environment. Children need safe, stable, and equitable environments to live, learn, and grow. Standard practice looks at things like social determinants of health, which are threats to that environment. And again, intimate partner violence, which is if children are in a home where there's violence, obviously it changes their sense of safety. But look at what hope-informed practice does. We talk with school districts around the country about positive school environments. We talk with county and local organizations about making sure that recreational opportunities are available to every child. That may mean improving the playgrounds, may mean reducing fees. And we talk about family check-ins. We used to talk about family dinner, but family dinner is not accessible to everyone because of their work schedules. But the key of family dinner is not the dinner, it's the family. and having routines where children and their parents check in is really important. We go to engagement, and correct me if I'm wrong, but I don't think there are any really standards about engagement. We talk, we go back and forth, but when hope-informed practice, we're looking for that sense of belonging at school, for like, do the children participate in the family? Do they have chores so that they feel that they matter at home? And what do they do after school and in the summer? And finally, emotional growth. There are screens for emotional growth, so if you're not doing well, you can screen using the ASQSE, a very common measure that's used in pediatrics and in childcare that talks about social and emotional health. And there's even social and emotional learning and anger management classes for people who have a deficit. What hope-informed practice looks for is we know that these child-centered play and having a safe place to do that, secure playgrounds, places to play basketball, opportunities to do all kinds of things. So who likes our logo? Raise your hand if you like our logo. Okay. This logo was developed for us by a team at Artists for Humanity, which is an after-school arts program in Boston. The kids get paid, and they work as a team, and in the winter of 2020, we contracted with them to develop our logos. And those kids, there's no screen for whatever is going on. Those kids are valued because they're artists, and they do very well as far as finishing high school, going on in their education, which is really wonderful. And it's because they're engaged in this project, or whatever project AFH puts them to work for. And we do a lot with community engagement. And I just wanted to mention, I mentioned before really quickly, these pictures are the speakers at our last summit. We had, Dina, was it 25 sessions? Almost. Okay, I exaggerate. Maybe there are a lot of sessions that we had. And we have standing groups, the family and community experts of hope, people from around the country who are parents or community activists, our National Advisory Board, who are really eminent people around the country who are deeply invested in child health and development, and also not a single one of them is shy. And they tell us when we're doing things right or wrong. We've developed an innovation lab where we try out things. We have a 6-month learning collaborative. It's very intense. Organizations apply. They're supported administratively to do this. We're just finishing now our 3rd round of it. And that Innovation Labs gives us the resources, the tools, and the knowledge of these organizations. We also have increased organizational capacity. We train people to become hope facilitators. Most often those are people who already do staff development. Facilitators who are really bit by the bug in organizations that want to change can become hope champions, and they help shepherd through transformation. And we have multiple research projects with partners like the American Public Health Association, the Centers for Disease Control, the American Academy of Pediatrics, all kinds of people. We have a long list because we want to expand this knowledge. And our role is to be a collaborator, that sometimes we're the lead, often we're not. We're there doing the research, and we're giving them some technical support. This is all good, but let's talk now about where the rubber meets the road. So what we talked about is the current system's focus on the negative. Many of the screening tools have been appropriately critiqued because they codify implicit bias. And when a participant comes to a program, whether it's a doctor or an after-school activity, and the first thing they get is a list of all the things they might be ashamed of, there's a feeling of judgment and creating a presumption of deficit. But look at our language. When we use these screens, we wonder if a family is going to disclose their problems, right? So it's not really a discovery in that way. But what we're doing with hope, though, is we're shifting the narrative. We know that people are defined by their strengths as well as their challenges, and hope-informed practice creates a presumption of change and a presumption of strength. And what this means is we're now positioned to do what's sometimes called goal-concordant care, which is you have that level of mutual respect that allows the participant and the provider to discuss their goals and how to get there. If you're in a situation where it's a judge looking at you and finding out all of your deficits, it's very hard to move from there to an actual dialogue. So we've been working with our advisory board and the family and community experts of hope, and really kind of figuring out exactly what this means in a child health application. Because Gold Concordant Care was born in palliative care, sort of the end of life. But what we think that we're now discussing is how hope creates conditions and training that support goal-directed care that's respectful, responsive, and purposeful. And when we do this, we're separating the outcome from the output. So parents and providers want a healthy child, they want the child to succeed in school, whatever that is. So the discussion is, let's make sure we're clear about what that goal is, and then take a respectful, responsive, and purposeful approach to getting the outputs of our interactions that bring us towards that goal. We have been really successful at beginning to change practice standards. So these are a few of the things that we have here. The prevention resource guides comes from the Department of Health and Human Services, the positive childhood experiences. Some of these come from the state, the Office of the Child Advocate in Massachusetts, and then the two on the right are just research papers that we didn't write that talk about positive experiences, and we're seeing more and more literature coming out that talks about this. So this is all good at an individual level, and now as an organization, the Hope National Resource Center is making the pivot because we want to have organizational change. And we've identified that there are 4 steps to organizational change: leadership commitment, examination of key policies, and we use the second round of our Hope Innovation Network, our innovation lab, to look at how people do intake or that first encounter. Staff capacity building, training, this is where all the facilitators come in, our online learning system, and continuous quality improvement. And in our model, CQI always includes parents and community members in setting the metrics and understanding the results. So let's talk about, yes, okay, let's talk about the impact. So we think about the HOPE framework. I gave you this list of 4 building blocks, but they're actually connected. So here's a way to think about the connections. First of all, adults help create supportive environments for children. These supportive environments give rise to positive relationships, positive childhood experiences, which happen through the relationships and directly through a supportive environment, engagement in developmentally healthy activities. So these shown in this kind of orangey color are the things that children do, and the green ones are things adults do. And these have social, emotional, and cognitive growth and hope. So these are all related, they're intertwined, and the beauty of this is that, when we first started doing this, we were in trouble because does one particular thing, which building block does it belong to? And the answer is that the building blocks themselves are connected, and that adults can create environments that are supportive, that support positive relationships and positive childhood experiences, that allow children to engage in developmentally healthy activities so that they can have social, emotional, and cognitive growth. So just to give one particular policy level example to ground this a little bit, Massachusetts is one of the states that now has paid family and medical leave. So when a baby is born, parents can take time off with pay to be with the baby. It's 3 months of pay. We know the importance of attachment during those first few months of life, and we know the stress that families, particularly poor families, face in trying to figure out how to both be with the baby and put food on the table. So this policy change creates a supportive environment that promotes that attachment that happens with infants, those positive relationships, and the positive childhood experiences that result from that. So looking at these things all together really gives a sense of directionality and marries the personal experiences that we talk about, the positive childhood experience that children experiences, and the role of parents and society and all these policies to create the environments that promote these positive experiences. So this is super exciting to be here today and talk with you now. We're active in 32 states. We've trained tens of thousands of people, hundreds of facilitators, and everywhere we go, people are taking this and running with it in accordance with what their own personal and organizational needs are. So we think we're at the beginning of a transformation we're planning to set up a program starting soft launch this fall for organizations to be able to become certified in hope-informed care. And all of this is because children's brains develop in response to experiences both positive and harmful. And I'm really looking forward to Raji's talk in particular, because we're going to hear about positive experiences. So much work has been done here in this building and with your colleagues about how children's brains develop in response to adverse and now positive experiences. And the HOPE framework is a translational framework. Translational, so something that people who are in the field or setting policy can understand and use. It's a framework that describes positive childhood experiences in these supportive environments, and these particular experiences and the relationships around them promote child and adult engagement, leading to social, emotional, and cognitive growth, and to resilience to adversity, to better health, and we hope to improve the public health and decrease the equity gaps in the United States. So it's really a pleasure to be here today at the beginning of this transformation. Thank you so much. If you want to contact us, there we are.